Hello, I'm Susan Manley, and I'm one of your hosts for today's webinar, Introducing HipTrac. Dr. Tony Rocklin will be joining us today to talk about and demonstrate HipTrac. This webinar is designed to introduce HipTrac to healthcare providers and athletic trainers. We would very much appreciate you sharing the information on HipTrac and our webinars with your colleagues and associates. In addition to the information that we will go over today, you will find case studies, research, patient and provider testimonials on the web at hiptrac.com. Now, on to the subject of our webinar today, HipTrac. It's the first medical device that delivers the same long-axis hip traction that healthcare providers perform manually. And just like manual long-axis traction, HipTrac relieves the pain, tightness, and other symptoms of hip osteoarthritis. Regular use enables patients to return to their social and leisure activities and exercise more, improving their physical condition, so that when they do have surgery, they'll be in better physical shape and recover faster. HipTrac was designed for independent patient use at home or in a clinical setting and was cleared by the FDA for sale in 2012. You'll see that it's easy to set up and use. Now let's do a quick rundown on HipTrac so you can see the unit, the individual pieces, and how they fit together. HipTrac is easy to move around and position. It weighs just 15 pounds, collapses into a small case, and the case itself has wheels for easy mobility. When we open HipTrac, the first thing that you see are the 3 grooves that allow you to easily position it at 10, 20, or 30 degrees of flexion. In fact, you can take it down to 0 degrees if that's indicated for a particular protocol. If you look across from the grooves, you'll see the silver pneumatic cylinder that drives the pulling motion created as a patient depresses the pump. And now to that pump. It's been carefully designed so that the amount of pressure is clearly visible as the patient is pumping. It doesn't require hand strength or wrist strength to depress. In fact, for a physically robust individual, it is impossible for the patient to pump it too much and hurt themselves. Moving over to the ankle and leg cuffs. The back of the ankle cuff contains a hook that attaches to the HipTrac itself. The cuff goes firmly around the leg, just above the ankle bone. The leg cuff attaches firmly just above the knee so that the lower edge is just above the knee cap. On the back of the leg cuff there's a strap that snaps into the ankle cuff, connecting the two. Both documentation and demonstration videos are available on the HipTrac.com website. We'll provide a link at the end of the webinar for your convenience. When you click on that link, you'll find all of the details you were shown today, plus the guides and protocol sheets included with each HipTrac. As you scroll down through the page, you'll see a quick start guide that includes pictures demonstrating how to set up HipTrac and put on the cuffs, an orientation guide that guides a patient through a test for his or her first use of HipTrac. It tests how their body reacts to traction and helps you set the initial protocol. A provider's protocol sheet that details recommendations for different conditions and pathologies. It also includes a guide on the side-laying protocol, an advanced protocol for people who have been using HipTrac for a month or more and would benefit from a higher level of traction force. Now that you've seen the individual pieces and documentation, I'm going to turn the webinar over to my colleague, Tony Rocklin, a physical therapist for the past 19 years and the creator of HipTrac.
Thanks, Susan. So a little bit about myself. So I've been a physical therapist for 19 years, specialized in orthopedics, and the last probably 15 years just had a special interest in the hip joint. And it's different because we have with our treatment, we're working with people with hip OA, FAI, labral tip. We're also working with people that don't have any hip disease at all. So sometimes in like your department, if you're working with firefighters that some have hip problems, some may not have hip problems, they just have intense training, want to relax. So we can talk a lot about pathology, and actually individuals don't have any hip pathology. So we'll talk a little bit about how we might use HipTrac differently for both those. And in the future, whatever we don't answer today in this 30 to 45 minutes, we can also email me, whatever you want to, and like I said, we'll get on the phone. So I became interested in the hip joint, started working with people mainly with hip OA, And as you know, when we have someone with hip OA and they've developed this compression problem, we want to decompress that and mobilize the joint capsule. And people would come in and we'd work on them, but we're working on an incurable pathology, right? There's no cure for arthritis. So we know that they might get better, but they're also going to progressively get worse. So we know manual therapy and therapeutic corrective exercise help to get them moving forward and feeling better. But what's to stop them when they go home? They're just working on their exercises. So people in the past would try to tie ropes to their legs, lie down on the door, try to push themselves away. They would stand on at the staircase with a heavy ankle weight and try to traction that way. They might get on an inversion table, which really can help a lot of people. But the problem with an inversion table is doesn't isolate the femoral acetabular joint, and your low back is being torqued. And for some pathologies, the low back doesn't like being traction and extension. And to get the specific forces that you need to actually effectively traction the hip joint, you'd have to be straight upside down. Your intraocular pressure would go berserk, your blood pressure would go up, and you could only probably tolerate that for maybe 3 to 5 minutes. So I look for a way to replicate it in the way that we would do it in the clinic, right? So we created HipTrac, and the thing about HipTrac, which is great, which you already know because you've probably been playing with it a little bit, is we can do it in any degree of extension, any degree of rotation, any degree of abduction, and up to 30 degrees of flexion. So it's nice to be able to customize it to that individual, whether they have capsular restrictions or they're just trying to get unloading in loose pack position or whatnot. So we'll go quickly through this just since it's going to be us and just be pretty informal, but you can use HipTrac for lots of things. So, when people have unilateral long axis traction, they'll use that for, lumbar stenosis, lumbar disc pathology. The thing about HipTrac, which is great, is that it almost isolates the hip joint. So you will have some unilateral lumbar traction that leaks up into the lumbar spine. But the cool thing is if you had somebody, let's say with an instability or a grade 3 spondylolisthesis, they can still, you'd want to not traction the heck out of that because that could irritate or create some hypertonicity in the lumbar spine. Well, HipTrac isolates that hip joint, so you can actually do that in the presence of a spondy and most likely not irritate their back. So that's the pro. The con is if they really wanted more lumbar traction, HipTrac could really help them, and you can play with that and see, but then you might want a more specific lumbar traction unit. I don't know if you have one of those, but those exist as well. So we'll talk about, lumbar, hip, and we also have a lot of young athletes, a lot of young firefighters that have FAI. They just don't know it. They might just feel like they have that stiff hip after work or on their shifts. And so it'll be really interesting for you to try to use that for people with complaints around their low back and hip. We also know that people that have even no hip pathology, when you use HipTrac for them, their QL, their psoas, all the muscles, paraspinal muscles, they're going to go into a relaxed state for a little while. So that's why we have pro athletes that really appreciate using that as a recovery tool. And so it'll be interesting to see how you use it for them. A lot of the colleges or the pro sports, they're going to have 3 or 4 or 5 of these lined up. So when guys come off the practice field or off the court, they're going to, come back, work with athletic trainers to, cool down and debrief. And then they're also going to be lying down with HipTracs, and it'll be part of the protocols. And so I could see a fire department using it that way as well.
Dina mentions, by the way, that they used it this morning for a hamstring strain of an external rotator spasm, and that the patient had a great experience and will be back on Thursday.
Yeah, thanks, Susan. Yeah, we have a professional track athlete who uses it for himself, but he also does some coaching. And one thing that he noticed was on a person who had FAI, one of the biggest benefits that he noticed was because it pressed into proximal hamstring, it sort of was a release technique when you use it hard. So you can use it for that. So it's not just for intra-articular pathology, even though that's why we created it. And so what we're noticing is that people will use that for any soft tissue stuff. Now, is that going to fix a hamstring tear? Of course not. But if you can create a more relaxed state, decrease hypertonicity, and you're doing all the other stuff that you're doing, there's no reason you can't do this. And for someone like you who's trying to work on this many people, you can't be everywhere at once. So you have people on a couple of HipTracs over here, you have those people doing exercises, and I'm sure you're thinking about all these things, racking your brain on how this is going to play out. But that is one nice thing about that. It sort of clones you to be more places, at the same time. So as we go, like I said, if you have any questions specifically, but we're going to go through and we can also talk about, there's 4 main principles that I want you to know that you'll learn. And I use analogies a lot, and I think it's really important that because patients can connect with analogies that make sense to them. And you know this as a former athlete, as a trainer, as a healthcare provider, but patients don't know this. And so what we've learned about HipTrac is it definitely works on a cumulative basis. Even though we do the orientation test, that handout, we do that to test tissue sensitivity and irritability. We know that during that orientation test, that 50 PSI, that's equivalent to 400 newtons. That's enough to deform the hip joint capsule. And that can, that's what it takes to distract the human hip, to decompress it. And so with a lot of people, their hips may not be ready for that, but it's totally safe. So when we do that, and we do that for 2 minutes about 5 or 6 times, we know that's enough to create a change. So if the person gets up from that orientation test and they say, oh, that feels really good. Actually, that doesn't hurt at all. Great. And then we know we can start them higher. But if a person comes in and says, and we know they're safe, but they say, oh, I feel kind of irritated, like that's kind of bugging me a little bit. That's still an equally great answer. It just tells us where they're at. It doesn't mean that it's bad for them. It just means that we better, instead of starting at a 10-mile run, we might want to start at a 2-mile run, right? If we're training for a marathon or whatever. So it sort of checks their baseline to see what they can tolerate, what they can't tolerate. So on that protocol, which we're going to be rewriting that in an even more specific way, but if they have a neutral to a positive experience, go ahead and just stay at that 50 PSI and ramp up from there. And there's always a law of diminishing returns. So somebody with a certain pathology their hips may not ever like to go above 75, while others like to go up to 100. And you sort of learn by doing like we do with anything. And it's important that the patients know, though, that they're not, even if they have a sore experience, they're not damaged by that. They're not injured by that. It's not going to be able to tear somebody's labrum. It's not going to dislocate anybody's hip, right? It's one of the safest things you could ever do. The body hip joint's a really tough joint. So you follow that protocol, and then no matter their experience, even if they say they have a good experience, by the time they get to the car, it may already go away, and they're going to be like, well, that's kind of a bummer. It didn't even last. So you got to give them that antibiotic analogy, right, where nobody takes one antibiotic and then complains to the doctor that they still have an infection. We need to accumulate the dosage and ramp up the dosage like we would with cervical or lumbar traction. So as they're using that, we want people around the 4th to 5th visit to really be able to connect with them and say, yes, I'm starting to see a change, a difference, or I have a better understanding of how to use it for me. That definitely, so 4 or 5 times in the clinic, and then let's say you have somebody that, these guys are coming to the station all the time. So let's say you have somebody that really has more pathology and they really want one for home. Well, that's when they can either rent one or they can buy one for home. But we don't like people to get one before that 3rd, 4th, 5th visit, because it really takes 3 or 4 times to really learn how to use it correctly. If they don't learn how to use it correctly, and then they're not sure if they're doing it right, and then it's not working, and it sits in their closet and just wastes their time. So just like if you were teaching somebody a single leg deadlift, nobody gets that or rocks that on the very first time. So the first time they come in the clinic, you're going to put it on them. But then the second time, 3rd time, and 4th time, make them fumble through it themselves, right? And then they'll do it wrong the second time, then you correct them. But at 3rd or 4th time, then what's great for you is they come in, you just point them in the right direction. You don't even have to be part of setting up, so it's saving you some time and labor as well. And then while you're working on this guy, they can be on that for 20, 30 minutes once they build up to that. So we know that we want them to work with it about 4 or 5 times before they get one for home, if they need one for home. We know it works by kind of a dosage, a cumulative effect. We also know that even if they have if they have a negative experience that first time, meaning that they just feel tighter or they don't feel better or something like that, it's sort of just like the first time somebody's flossing their teeth and their gums bleed a little bit. We break up that tissue intentionally, make them bleed and get irritated, right? We do this all the time, but we don't stop doing that. We want to keep flossing. So with HipTrac, even if they have like a sore experience, we may back off a little bit, but we want to consistently keep them going, right? So they can get over that flossing phenomena, remodel that tissue, and then see what happens after that. That's super important if you have somebody with, a hot hip, a more irritated OA or something like that. But now that we've done it on thousands of people, we've done it for, multiple years, we have more confidence in that we see the trends of people going through that. Other key concepts are, make sure that person, if you have somebody that is, say, really hypermobile and they have a labral tear, that's not dangerous to them. But what we've noticed is that the person's like that 19-year-old, super crazy, hypermobile, dancer-like body. I don't know if you have a lot of those in the fire, but you never know. It doesn't hurt them, but what can happen is they can feel good while they're on it, but then they're a little bit toned up afterwards. And that's gone in 24 to 48 hours. But like, we don't want to traction somebody super hard that's already hypermobile, and you obviously get that. So if the person is having issues and they're not super hypermobile, then there's really no worries, go for it. But if you have somebody that feels good with manual traction, well, some of those people, they just need a CrossFit band or a super band. HipTrac is too powerful for them, and there's no sense. You can still use it at 10 or 20 PSI when you have there in your clinic, but no one's going to want to rent or buy a powerful HipTrac. They'll only use it at 10 PSI. So in those cases, right, we can use a CrossFit band or a super band or something like that. I think what we'll do now is we'll talk more about specific questions and how I use it in the clinic and supine versus sideline. But I'm going to bring Aubrey in. Aubrey is a physical therapy assistant here at the clinic. And I'm going to have her be the model. But Aubrey, why don't you come over here and sit in this chair back there a little bit. Say hi to the crowd.
Hello.
So we're going to move this camera down so that we can see your feet. So if you need to move in that area. Do you see a lot of OA or stiff hips or FAI or labral tears or even post-op? We have people, there's surgeons around the UK and around the country that they want their patients to use HipTrac first day post-op after arthroscopic surgery. I don't do that here in Portland. We usually don't start any manual therapy till week 3, but it is okay to use HipTrac after arthroscopy if they have stiff hips. But at this point, even though we'll do manual therapy and I'll do manual traction and manual joint mobilizations on a hip replacement, and I know that you've seen a few of those, we do not want to use HipTrac on a hip replacement yet. We are not worried about it dislocating their hip. It's very strong. It's not going to dislocate. But if that person has any hip issues, they're naturally going to want to blame this contraption. They're not going to, it's not because the prosthesis or because of the rehab or whatever else. So we're just going to be protective and not use it on a post-op hip replacement yet. But arthroscopy, totally safe. When manual traction is appropriate, HipTrac is appropriate. All right, so one of the most important key concepts is let's take off this shoe, and then roll up your pant leg just a little bit and sock and stay on. So what's really critical is that, all of us are skinniest right above our malleoli, right? So we want to make sure that this bottom edge is just right on top or right above that. If we're going to be pulling hard, we put that up here, it may feel like it's going to stay, but it's eventually going to start traction, slipping off, and it's going to be way too loose for down here. So in the beginning, I put this one on way too hard, and people might say, well, I'm getting a little tingling or numbness. It's totally safe. It's going to go away. But what the goal is how loose can you put this on so that it's comfortable, but without it slipping off? And when you add the above the knee binding to it, this one doesn't have to be that hard. So just, so I always tell the clients, like, it might be a little too tight, but as you use it more, it doesn't have to be that tight. So I don't worry about where the hook is. In the beginning, I'll just wrap it around so I know that that edge is right on top, right above their malleoli. And you want to make sure that you pull that around tight. It doesn't have to be crazy tight, but it just has to be nice and conformed so there's not a lot of gap in there. And then once it's there, before I do the secure straps, then I'll rotate so the hook is centered to their Achilles tendon. The reasoning behind the center of the Achilles tendon is the way it's designed is that will force the person into whatever available external rotation they have, which is the more loose pack position, right? So that's where we like to start people. But intentionally, we also like to, the goal, especially with a stiff hip or capsular restrictions, is we want to push them towards a closed pack position. Well, to do that, we need to do more internal rotation, more extension, and more abduction, which you'll get in sideline. But even in supine, by starting that hook over here, or starting that hook more over here, that will dictate how much rotation IR versus ER they're going to go in. But we always start everybody neutral, Achilles, and that's usually the comfortable place to start, okay? So once that hook is centered, then just make these ones really tight. Now scoot forward a little bit and straighten your leg out. And a lot of this is going to be review because you've already set somebody on it. So maybe there's a few key things here that as we go that you might pick up a little bit. Yeah, so the super band. So you've used the bands for joint moves like a mulligan mobilization or mobilization with movement. And that that's great to use for home as well. Do you use a seat belt in the clinic to wrap around their hip and mobilize them that way? Yeah, so there's some good things there too that we can talk about, and I can shoot you some videos. And I don't know if you get the orthopedic journal from the American Physical Therapy Association, but we just published a journal article in the January 2017 issue. Why don't I'll have these guys remind me and I'll send it to you. There's a lot of manual therapy techniques for joint mobilization, and then there's some of this stuff that we're reviewing today. And there's not the super band mobilizations in there, but I'll send that to you. But you can also look at the HipTrac YouTube channel, and there's a smattering of self-mobilization techniques with the super bands too, that 6, 7, 8 different ones that a lot of people with that are trying to manage OA or trying to manage a hot FAI that they can do that. Yeah, the Rogue fitness bands are great too. Yep, that's great. Okay, so what you're going to want to do is you're going to take this. You're going to want to make sure, again, so this is right above their malleolus, and this is bottom is right above the top of their patella. And just make that, it might be crazy tight on that first one, but you want to make it kind of tight. And then this one, same self-explanatory, just wrap those around. And then, of course, you have this hook. Now, hopefully the HipTrac you have has the new hook. So this one has the old hook. I don't know if we can see that. It's black. Where can I put it? Here, I'll use that as a background. This is a bigger hook. And for some people, it was sort of stabbing them in the back of the calf when they're under higher pressures. So if that happens, you sort of turn it sideways or you put a little pillowcase in there. But the new hooks are smaller, more low profile, and they should be comfortable. In addition, Susan was talking about in the introduction, when you use the HipTrac all the way closed in 0 degrees, the new ones have a cutout so the hose doesn't get crimped. Before, the old ones, we would just stick a shoe or a towel in the end, and that would just keep the hose from getting crimped so it was almost 0 degrees. But as you progress people, some people you'll stay up in loose pack, but for people with the stiff capsule restrictions or OA, we're going to want to take them closer to closed pack in supine to there until we go to the sideline and do extension. But for those guys, when you use it closed, the hose should be okay with the holes there. All right, so then we're going to clip that there. Go ahead and stand up and turn around, Aubrey. And then right here, we just want to make sure that when they're in extension that that's tight. So they don't have to do it in standing, but they can do it while they're still sitting there. But just make sure that's all lined up. The reason we did that, go ahead and turn around, is because when it pulls like that, there should be no patellofemoral. It should almost like unload off of that. And this is the part that really starts to slide and dig in down there in quad tendon. So there should be no patellofemoral and no major pain down here. But people can walk around like that and that's fine. But make sure that they really get that secure tight. You'll have people that'll say, oh, it doesn't work, it keeps slipping off. We now know that if they can't, well, it's kind of hard to say, but it's user error. So we know this will, on the biggest guys, on the biggest pools, it won't slip off when it's done correctly. So the good news is that if it's not working, that just means we have more education to do with that. So you can see down here, I have it set up at 20 degrees. And that's just where I start people in the orientation test. Some people might be more comfortable at 30 more loose packs. Some people might be, but the higher you are, when you're at 30 degrees, people tend not to feel a stretch. So even on a normal hip, when you get into it, people think there should be some big, sexy stretch at their hip joint. But there's not supposed to be. Now, some people might feel something, and a lot of people might feel some placebo stuff or like, wow, that feels really good, and that's fine. But if you wanted somebody, if you have a quote unquote disbeliever or somebody that I don't really feel like that's doing anything, you take them down to 0 degrees or 10 degrees and taking them up to 70 PSI, you can make a believer out of them really quickly. They may not feel it in the first go, and you're not going to hurt them, but some guys need to know that something's happening and they don't want to have the blind faith of antibiotics. So you can take them, you can start them lower and take them higher in pressure, and they will definitely feel something when they get up. But sometimes you got to do that, but we don't want to if we can help it. So what Aubrey has done, she put the pad, the ischial tuberosity pad, so it goes vertically like this. And if you have somebody that wants more padding or less padding, that's fine, but that should do it. Now she's going to take that ischial tuberosity of her right leg and put it up there, and then she's just going to lie down. She'll put her involved foot not up on the hooks, but just on the side here. And then what she'll do is she'll grab her pull straps. She's going to pull that into her as hard as she can in that area. Now, what she'll do is she'll dorsiflex her ankle and extend and try to reach up to the highest hole she can. And I don't want people to, especially if they have a really hot hip, we don't want them to fight for it and irritate their hip flexors, but we want them to get to the highest hole they can. And nobody ever really does. And you'll see in a second when we start tractioning, it's important to start at the highest hole, because if you start really low and there's a lot of slack in the system, people will start to complain to you that, oh, it's hit the top. I want to go more, but it won't go up anymore. It's stopping. That's user error. We've had the strongest, biggest, toughest athletes, and they won't beat the unit. And if they do, then we show them, if they want more. I haven't had that yet, but there's a way to show them how to get more in a different position. But just know that usually the mistake is they just put into the hook too low and they didn't take all the slack down here first. Also, sometimes when they get into it, they forgot to release the track all the way down before they got in. It was already like 60% exhausted, and they got into one of the lower holes, and they go and they hit a wall and they can't go anymore. So again, if somebody ever complains to you that they want more but can't get it, it's usually a user error. There may be a small chance that, yeah, these machines don't last forever, so maybe a cylinder is leaking or something like that. But if that ever happened, there's a 1-year warranty, and we'll get that replaced right away. And there's always spare parts and stuff that we can put on there. Okay, so now she'll grab her hand pump. Now before she does that though, so she's going to be relaxed, right? So she's going to make sure, I always kind of grab their foot and try to just relax them, because a lot of people think they're relaxed, but they're not relaxed. She's at 20 degrees of flexion. She's in her available external rotation. Now we want to go into abduction. So to get the abduction, I'm going to have Aubrey show us the wrong way. So Aubrey, and this is kind of funny, Gina, because even providers do this too. If I want them to have more abduction, I don't want them to lift up their injured leg and move this device, right? So do the thing where instead of rotating, you just slide your ischial tuberosity. So we don't want that. Oops, sorry, bad camera work. You're like, you don't want what? All I can see is her foot. So we don't want the person to slide, so slide back. So there should be no sliding. We want them to rotate around their tuberosity, around their hip joints. So now she's going to take her upper body to her right and her left leg to her left. So now it looks like she abducted her right leg, but she just moved the rest of her body around it. You're going to run into that a lot. People just don't understand. Okay, so, and then you decide based on your clinical experience, based on your gut, based on your patient's range of motion, or whatever you think, we just want to add a little bit of abduction in both loose pack and closed pack. So now and the other leg, let's say they had an irritated lower back, that other leg could go up on a chair, a bolster. Zach, why don't you walk around and put that chair underneath her leg? Just put it underneath her left leg like a bolster. Yeah, not too close to her, but yeah, kind of like that. So she can just have it out there. So sometimes I'll do this on the first time just because it's more comfortable to their lower back, but it's not necessary. Some people, when they put that leg flat along the ground, they like it better. They feel like they get a better stretch. So again, this is sort of like the creative healthcare provider nuances that you'll just know based on your experience and your patients. Sometimes we'll even put a hot pack, go ahead and point through your groin. Like we'll put a cervical hot pack right through there to the hip joint, and that helps to relax the muscles too so they can have better traction. So Aubrey will start pumping up now. As it pumps, we should see that track moving up. Yeah. So we have her take it to 50 PSI, and you've done this already, so this is all pretty much review for you, so I'm going to blow past this. Okay, she's doing the fast track, working on, yeah, not that fast. Okay, go and relax there. Pretend that's 50. She'll hold that for 2 minutes and then she'll hit the release button on that, okay? Now the first time, when people are using it regularly, we don't want them to have to release it all the way down and then they'll have to pump all the way back up. Just like cervical lumbar, you might come halfway down, right? And then go back up. So they don't have to, get carpal tunnel syndrome or something from pumping too much. But that first time, Dina, I really like people to, because when it goes up there, it goes up so slow and smooth that they don't realize how much pressure they're under and they're not sure something's happening. But the look on their face when they hit that release button and they stay relaxed and let it all the way down, it really kind of reminds them like, whoa, I'm really under a lot of decompression. That's great. And I think that helps them mentally too. The main thing is once she releases the pressure all the way down, then she'll take the pad out from underneath her and kick the chair out of the way. Yep. And then it's important that now you have a little space between the where the pad was between the HipTrac and the radial tuberosity. So she's going to grab her pull straps, and when she pulls that into her, she's going to bend her knee and keep it there. And now what she's done is she's created a little bit of slack because you can't just lift your leg out because you're hooked in. So because she pulled that into her and she has a little bit of space underneath her fossa now, she's going to hold that HipTrac into her as she dorsiflex and extends out. And then it pops right out. And then I just have them go right down there and then now bend their knee and slide their heel. Not worried about scratching the unit. They're just going to go back and forth and just try to get some movement. We like them to do that for their psoas and iliacus before they get up because it just helps. It's kind of like coming out of cervical traction. You don't want to just yank your head out of cervical traction or lumbar traction. You want to kind of move around a little bit. So go ahead and sit back up, Aubrey. Now, she's going to move the ankle binding to her medial malleoli. So she's going to just undo it and turn it to the side. You can stay connected if you want. Sometimes it'll rotate or just loosen the two little straps down there and then you can move it if you need to more easily.
That worked.
Yeah. That one can stay like that, even though when you do sideline, you'll move the whole thing, but you have to have the hook coming out the medial malleolus when you go in the sideline. And you could spin that too, but it's not always necessary to spin the above the knee, okay? So what we're going to do is we're going to set her up in sideline. So you don't really need the pad anymore for this. What we're going to do is I've used the HipTrac up against the wall, in this case the plinth, but against the wall. You want something, so now your body weight is not actually stopping the HipTrac. And so what she's going to do is go ahead and lie down there. I'm sure I have enough room to squeeze in there. Is she gets as close as she can, right? So she's going to put her radial tuberosity as close as she can, but she's not going to have her body weight necessarily stop the HipTrac. And now what she can do is she can put her leg up on in the medial, and now she's at 20 degrees of abduction. She would still use her pull straps to kind of pull it into her, but you can kind of get like that. And some of the people you're working with are going to be, most people are going to be athletic, right? They're going to be able to do this no problem. Now she's in there, that puts her into relative internal rotation. So you can't be accidentally rotated, it kind of forces her to roll over. Now, there's not going to be any stress, like on a valgus stress on MCL, but if people complain about that, there'll be a pillow down there, is you could put a little towel or something, or a pillow or something in there, but it's not absolutely necessary, okay? Or even like a small towel or something like that. Nobody's really complained about it, but visibly they might, maybe they need that. Now, it's important that we go ahead and come out this way a little bit. Yeah, so we like to keep this foot flexed like this. So that makes lumbar spine, because when you go into sideline, and you'll see here in a second, it's for more extension. And so the lumbar spine, we don't want that to be hyperextended. So by locking out the bottom leg in a flexion lock like that, just makes the lower back much more tolerable. Now, the important thing of this, there goes the camera work again, guys, is when we're looking down at her, you can see how she's not fully extended. She has her upper body kind of folded forwards. So now, yeah, come back into full extension. There we go. So at this point, she's not flexed. It'll almost be like if she was supine, the HipTrac would be all the way closed. Now, if we want more extension, it's really important that the patients, because they'll naturally want to flex their trunk, which is flexing their hip. So if she slides her pelvis and her sternum at the same time, then we know she's going into more hip extension. Can you see that okay with my amazing camera work? And we have a little video, like a little screen thing that Susan and Don can send in, you can see online. But just make sure that they're purely in that extension and they're not flexing their trunk too much. But when you get people in this position, for most people, especially with OA, or anybody that's limited extension, FAI, and with FAI, it's a bony problem, right? But people with FAI, if they get irritated, they will start to develop capsular limitations. So we're not mobilizing somebody's hip to change a cam or pincer lesion. We're not mobilizing their arthritis. We're mobilizing the joint capsule that gets irritated and tight in the presence of those pathologies. There's a lot of people that have OA and FAI that don't even know it. They live their whole life and they never really know that they have it. But for a lot of us that get capsule limitations, it's important that we do that. So anyways, that's how we would do the sideline, and then you can control the abduction through the support legs down there. And then she would traction the same. It's a little bit more awkward to pump and sideline, but you can do it. All right, thanks, Aubrey. You can get it. And then get out of there. She just has to kind of scoot closer to it and bend her knees, and then she can just extend out of it. Again, with specific hip flexor pathologies, doing a joint technique for a muscle problem doesn't fix that problem. But part of getting people better for any pathology is creating an optimal environment for healing, right? So yeah, you might have to do specific active release and positional release techniques to the psoas, to iliacus. You're gonna have to make glutes be smarter and strengthen and blah, 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 all the biomechanical things that you'll do. But yeah, there's no harm when you're working with people to put those muscles in a more relaxed state. So I guess what you would have is you'd have units there. They would use them in the case where if somebody couldn't come in, because what some people with OA will do is they'll use it once to 3 times a day. So if you have guys that are having trouble sleeping, they wake up at 2, 3 in the morning when their bodies are coldest and they just can't get back to sleep, or they're having trouble sleeping, have them use the HipTrac progressively, in higher and higher intensities right before bed, and that helps a lot of people sleep through the night. We have other guys that'll go out golfing or something, right? And they'll say, well, I don't want to walk the course because my hip hurts. They'll use the HipTrac before they golf. And we have other guys that before or after, they'll use HipTrac afterwards as a recovery tool. So for example, we're going down Thursday to see the San Francisco 49ers because they're interested in having HipTracs just for recovery. They have young athletes that some may have hip problems, but they just want a tool because when I played basketball at Oregon State, we would come off the court and the athletic trainers would pull on our legs, stretch us out. It would just be a typical recovery protocol just to get ready for next day's intensity, right? And so HipTrac has a place with athletes or even active individuals that don't have any hip pathology, but they just want to work on relaxation of those muscles around there. So and all the things that you've mentioned, you absolutely can do that. And of course, we're not going to confuse that with, it doesn't cure cancer, it doesn't cure hip flexor tendonitis, it doesn't, it's a tool that you would use to help create environment. In the case of a specific intra-articular hip problem, it absolutely is working on the pathology, the secondary restrictions around that pathology. Any questions that you can think of so far that we haven't talked about that may apply to your specific situation? So let's go through our checklist. You know how to use it. You know a variety of pathologies that you'll use it with. You obviously know your own billing and how you're contracted with them. So I won't be able to help you with that. So I don't know if you're billing insurance or if you're just, is it fee for service, like cash pay, or is it, I'm not sure how you're coding that, but you could use the mechanical traction code. And you also have a better understanding of the psychological side of things, like how to help those guys understand that it's going to be cumulative for some, while other people can feel something right away. And for the people that get irritated, they're safe. They're not going to be able to hurt anybody. There's the normal contraindications, malignancies, fractures, the obvious ones that you wouldn't do that anyway. But I'm going to send you, when we get off here, I'll click a button that'll send you a link. You can go to that and kind of play around and provide some feedback. And then also Don and Susan will follow up with you, and you'll have my email. I'm in the clinic full time,